I think we're going to begin our next panel if we're all set. So this panel's on reaching our cardiovascular health goals. We did a great job, I think, today kicking off with what we now call the Sydney Report, using data to really set the stage for why we want to have this conversation that we're going to have today around cardiovascular health. And we transitioned to then applying the challenges we're seeing in some of the risk factors in the preparedness of our military. So it was a nice application. And then we really moved to a conversation around value and access so that we can make quality health care affordable and accessible. And so now we're going to talk about risk factors and cardiovascular health, and how is that progression going? What are the trends there? And what do we need to do differently? How do we think about some of these great cross collaborations that we're having in value and access? Where are they happening today? And what more do we need to be thinking about when it comes to cross collaboration? I think we're going to begin this conversation. We have Dr. Melnyk, Dr. Thompson, and Dr. Penso today to help us with this conversation. And I think Dr. Thompson is going to kick us off with a few slides that set the stage for why we have a focus on cardiovascular health risk factors.
Thank you. Yeah, I think maybe we've heard enough actually through the Sydney report and others this morning, but we did want to just ground us in a couple of slides that I think are going to show up here. Maybe not.
Or not. There you go.
Okay, so this one, the first one here, I wasn't sure which one was going to be first, but these are data from 2010 to 2017. You're the first ones to see these, by the way, because they just got updated with the 2017 data, showing the county level percent change in heart disease death rates for 35 to 64-year-olds. So different from what Dr. Sidney was talking about principally in the 65 plus, what this shows is at the county level, the red denotes an increase in cardiovascular heart disease death rates, the black or the gray to black, a decrease. So the brighter or darker the red, the greater the increase, the darker the gray or black, the greater the decrease. It's probably apparent, but this does mean that the majority of counties, actually about 61% of counties, saw an increase in death rates, not the number, but the death rate in this younger age group of 35 to 64-year-olds. These are our employees, our workers, our employees, and yes, feeding into the next silver tsunami that we'll see coming. So I think these are very alarming data that we have, and we've put out a lot, as has the American Heart Association and others in the last year or two, showing what we know is coming with the working age adults. The next slide is very hard to see, but it's cardiovascular mortality kind of writ broadly. It's both, there's a line there for heart disease, there's a line for stroke, and then there's a line for all cardiovascular disease deaths. And the real point here is it's broken up, there's by gender, by race, and by ethnicity, but the message is the same, and that is that our cardiovascular mortality is the decline that we have seen for decades, that we kind of came to rely on continuing, has more or less stalled. And in a few cases, and depending on what group you're looking at, as Dr. Sidney showed us this morning, in some cases it's actually increasing. So this is why we're talking about the need to really make drastic improvements in cardiovascular health, and not a decade from now or 2 decades from now, but as soon as possible.
So maybe I'll start with you, Dr. Penso. What do you see as a priority when we think about reducing the risk factors that are contributing to these trends?
Probably number one, probably maybe even number 2 and number 3 is going to be high blood pressure, hypertension. We know that it affects a large percentage of the population, especially as you get older. And we also know that our control rates aren't where they need to be. We looked at data. I represent the physician community, the provider groups. We represent at AMJ over 400 medical groups and health systems across the country, about 175,000 physicians. And we run data on them. And we found when you look at their practices, what do they actually see? About 45% of the patients that come in the door have high blood pressure. And it's actually 62% of the work RVUs, which is the amount of work. That means they may see them more frequently or have higher intensity. So it's very common in our practices, and we know there's a lot of room for improvement, and probably the number one modifiable risk factor that could be improved.
Dr. Melnyk, what about you? What do you see as the biggest priorities?
I'm going to start with a story. So when Million Hearts was first launched, 2 days after the announcement came out, I reached out to Dr. Janet Wright, who I really respect, who has done a great job at leading that first phase. And she didn't know me at all. I said, "Hi, Janet. I'm Burton Melnyk from The Ohio State University. And I would like to know, how can universities partner with Million Hearts to prevent heart attack and stroke?" And Janet tells this story. She said, "Bern, I was kind of speechless when you called me, because I hadn't thought about universities as a strong collaborator in this initiative." So right after that, our university, our colleges of medicine, nursing, and pharmacy launched a free online Million Hearts Fellowship Program to screen people across the United States and educate them about the ABCs. To date, we have screened over 76,000 people across the United States. We have some good partners in the room today. Chris is here from the Missouri College or Public Health Department. We have 170 collaborating universities, colleges, public health departments, community organizations who are using those modules. But I want to get back to risk, as you were talking about. We just published data from about 60,000 people who have been screened across the United States in the American Journal of Health Promotion. And what we showed from that analysis, controlling for age, race, ethnicity, and BMI, stress is a leading predictor of heart disease, high blood pressure, high cholesterol. And I'm going to continue to advocate that we put stress as another key indicator to cardiovascular disease and really start tackling that along with blood pressure, cholesterol, and smoking. In that study, it was the younger people that reported higher stress. It's this population that Betsy just identified. So I will keep beating the drum on stress and mental health.
That's great. So we've heard about hypertension, stress, cholesterol, the beginning of collaboration. Dr. Thompson, anything else you might want to round out when we come to what we might want to prioritize as we think about this?
Well, I would vote along with Jerry that hypertension control, well, first let's back up a little bit. There was a lot of talk this morning about prevention of hypertension in the first place, and we all know that's where we want to be eventually. But as long as we have 78 million people with type 2 hypertension right now, we really need to prioritize hypertension control because that is where we can save the most lives and improve health by far the greatest over the shortest amount of time. Cholesterol management's right after that. Something I think we don't pay enough attention to, and I still, hypertension control is where we are going to focus, but it is cardiac rehabilitation and the really underwhelming use of hypertension, cardiac rehabilitation among those for whom it's indicated and actually covered. So that would be the only one I add. Besides, I hope we'll talk more about we need to do some things differently to achieve what we need to in hypertension control.
Well, that was a nice segue to my next question. So do you want to start with that? What do we need to do differently in the control of hypertension?
Well, I think there are a number of things, and I know Bern's going to probably say more about what she was just talking about. One thing that I think where I sit as the director of the Division for Heart Disease and Stroke Prevention at CDC, we put a lot of funding out every year through state health departments, some local health departments, tribes, and they do great things. But we will never have enough money to fund every community to do what's needed, and we have to engage new partners and ignite and excite new partners to do this work alongside us and maybe independent from those of us in public health at times. So we have started some significant work in the area of engaging the private sector. Our Million Hearts Initiative has done some of that along the way, and some of the communities we fund certainly do. But we haven't, as a division, really targeted engagement of the private sector and others in true multi-sector collaboration like we are now. So I think that's an area that I think we hope to make a lot of inroads into, because there are very specific things, whether you're talking about employers, health plans, funders and philanthropy, academicians, that all of these different sectors can do. And it's been fairly well documented that doing it together gets you further.
What would you see as the biggest barriers to the collaboration across when we think about bringing all these groups together? Maybe I'll start with you, Dr. Penso.
Well, collaboration is hard. That's where I would start. We all tend to work in our own organizations. We all tend to see things through that lens. We get familiar with the people that we work with. In my organizations, the medical communities, we tend to think, well, everything happens within our four walls. And when the patient leaves, well, they don't exist anymore. They're out in the community. But we know that the patients spend the majority of their time as people, not patients, out in the community, and that our organizations need to find ways to collaborate with community organizations, with government entities, with the health plans, et cetera, if we're going to really make a dent in this. You just can't, one sector alone just can't manage something as big as hypertension, let alone some of the other problems we may want to address like diabetes, obesity, et cetera.
When I think of collaboration and people who can put structure in place so that it's easy to collaborate, I think of you, Dr. Melnyk. Can you share with us some of the key critical success factors you see when it comes to bringing cross-sector collaboration together?
I think vision. So much of the time, we often get steeped into details of a strategic plan, and we often forget how critical vision is to keep people excited about where we're going. So establishing a great team vision across sectors is super important. We are very, for instance, large university at Ohio State. We have 66,000 students, 40,000 faculty and staff, 7 hospitals. My charge as Chief Wellness Officer at Ohio State is to improve population health. That's a big character builder. But because we have not siloed, and we have collaborated across disciplines. We have seen a 7% improvement in cardiovascular health over recent years, and we are in a negative healthcare trend for faculty and staff health for the last 3 years. We started a Million Hearts Clinic. And that's a collaboration. It's nurse practitioner led, but interprofessional teams that have nurse practitioner students, medical students, pharmacy, exercise, dietary students involved. And that's making a big dent. So again, collaboration with vision and execution really gets us to outcome.
Anything else my other two panelists would like to add?
So before I came to Washington, D.C., I was in the San Diego area. I'm a family doctor by background and worked on a very exciting collaborative in the San Diego area called the Right Care Initiative. Our vision, so the vision kind of brought that up. Our vision was to have 0 heart attacks and strokes in San Diego County. 0. Now, of course, that's kind of hard to achieve, but that kind of united actually the entire community, be it the the government. We worked very closely with the county. We had all the providers involved, 90%, including the VA, the DOD, and all the private sector, and all the community clinics working together, and even community workers. And it was a real exciting project. And I'll never forget, Dr. Tony DeMaria was our leader in the San Diego area out of UC San Diego. And he, on TV locally, would lead the effort, and he'd say, we're all going to die, but we shouldn't die of something stupid like heart disease and strokes that are totally preventable. And that kind of, that vision, it's funny, but it kind of united us all around this goal of let's make San Diego a heart and stroke-free zone.
And I would just echo some of the things that they've really already said, but it's one, getting the right stakeholders at the table, to having a vision, but maybe even beyond that, being very specific about the goals. I think we're all, especially when we're trying to get multiple sectors together, private, public, different parts of the government even, we all have full-time plus jobs. So to bring those folks together, they have to know that what they're going to do is going to mean something at the end of the day and have real impact. So being clear about both what the goals are and sort of the evidence that those can be achieved, I think, are critical.
One area we've not, I think it's been on around the rim of our discussions is the issue around health equity and the need to address health equity as we're looking at these risk factors and the impact social determinants clearly play. What do we need to do differently when we think about how we are going to reverse the trends that we have on these risk factors? And then where I'm headed to this is, are we, as we think about cross-sector collaboration, who have we not maybe yet included? What do we need to do differently to make sure that health equity is at the forefront of our strategies and our cross collaborations? Why don't I let Dr. Melnyk start with that?
I think, again, we have 33 million people who live and work in institutions of higher learning. Within those institutions, there are so many health sciences colleges, medicine, nursing, public health, optometry, dentistry. An emphasis in so many academic institutions currently is this issue of equity and teaching our students how to address that. But if those of you in the room have universities close by you, I would really encourage you, reach out for collaboration. We've got to leverage the millions of health sciences students who we have throughout this country to help us reach our goals. It's possible with more leveraging and collaboration.
Anyone else want to take a stab?
Sure. So,
No.
yeah, I mean, well, where to start is really the issue. I think in the booklet you have the new strategic plan for our division, and as several speakers have talked about using a health equity lens, we didn't use that terminology exactly, but as we went through a very rigorous strategic planning process over the last year, we did decide that we had 3 foundational elements that had to be incorporated and considered in everything we did. And one of them was around health equity, and another was priority populations, which are sometimes the same and sometimes a little different. So I think one, just being very explicit that is embedded in everything we do, whatever type of agency you work in. I think though, in terms of and so that facilitates it, right? But in terms of the barriers, as a government employee, particularly one in uniform, I can't do anything about this, but siloed funding in the way we fund health is a real issue with the inability to really broadly deal with social determinants of health, because if we don't reimburse for that, we all know it's not really going to happen on the scale that we need it to. So that's just a thought for all of you who aren't federal employees to think about. I'm sure you do already.
From the provider community, many of the groups I work with have very detailed quality improvement programs. So the question is, what's on their dashboard? What are they looking at? And that's the question that I ask them. Are you looking at racial and ethnic disparities in measuring hypertension or cardiovascular health? If not, I think that's the first step on the provider community. Let's just make it transparent and awareness. Are there differentials in your population? And then if so, that then would lead to the next step of then how do we begin to address it? So from our provider groups, that's where we're starting. They just have to bring it up to a level where it's on the dashboard and apparent, and probably even for the quality programs at a board level.
Jerry, I'd like to follow up on that. It gets back to what Michael said earlier. 85% of employers have wellness programming, but why? Then why are we seeing this trend that we're seeing? Some of this gets back to evidence-based quality improvement. People have programming in place, but they don't have good outcomes measurement strategy. And if they're using good outcome data to feed back in to quality improvement, looking at metrics like you're talking about, I think we would see better movement in the right direction.
If I could just say one more thing, because I think all of the comments tie back to a concept that we heard from several speakers this morning, and that was the alignment of incentives with the outcomes we want to see, and being very explicit and clear about the desired outcome being elimination of disparities. And if that's on your dashboard and you have the metrics and you've aligned incentives properly with that, we will make great progress there.
So in order to overcome these barriers and have these cross-collaborative work streams, are there areas of industry, are there community partners that we are still lacking that perhaps we need to still bring under the hood to address these risk factors? Any key ones come to mind? One, for example, that when I look around this room, and at AHA and I know CDC and others do as well, is some partnership around technology and technology companies. And we've been thinking specifically in the areas of rural health. And one of the limitations, right, for telemedicine, we had a conversation around telemedicine, is if you don't have cell phone towers, you can't have telemedicine. So just to stimulate sort of some ideas, and technology companies are often, and I use that term obviously very broadly, I think one player that we need to bring under the hood a bit. Are there other ideas perhaps you all may have?
I think you're bringing up a good point, and that is we have to think out of the box when it comes to collaboration. I'll give you another example on how we've just done this. So we partnered with the National Forum at Ohio State. We are doing a heart-healthy football game in the Horseshoe on November 9th. But the theme will be heart health, the messaging for people. The band will be doing heart formations. But that's something that people don't think about. We have a crowd there of 105,000 people. We will have messaging. Mayors from throughout the state who are being recognized at halftime on the field that are doing Move with the Mayor. So I think, again, we need to think out of the box sometimes to really reach sometimes hard to reach populations. That's just one example.
You know what came to mind when you asked the question is what I'm seeing in my provider groups, and we're seeing in the health plans as well, as a real renewed interest in the social determinants of health. Now, they've been there all along, but some now they're like the hot subject right now if you go to any of our conferences. So somehow they've been rediscovered. And why have they been rediscovered? Because as we're now becoming accountable for populations, both the cost and the quality, people realize that some of these other factors, you can't get blood pressure control if you can't get to the pharmacy, you can't afford your medicines, or if you can't, afford your diet and the right kind of foods, et cetera. Transportation, behavioral health, affordable housing. All of these are now being looked at by our medical groups in combination with their health plans that they're working with. There's new flexibilities in some of the federal regulations, especially on the Medicare Advantage side, that are very favorable. Many of our groups are doing innovative things, partnering with Uber and Lyft so that people can actually get to the doctor appointment, and looking at things like fresh food pharmacies, et cetera. So I think there's a lot of potential innovation. I don't know if those are all the solutions, but again, I think if you can't get to the doctor, if you can't afford to go to the doctor, if you can't afford your medications, if you are depressed, all of those almost have to be the base to be addressed if you're going to address some of these other risk factors.
Yeah, when I think about who's missing at the table, I think it probably differs for every entity in this room to some extent. But for us at CDC, and I think for many of the folks we fund, we've done a good job at engaging many facets of the public sector. But as I said at the outset, we really need to do much more with the private sector, with employers. Health plans we've had more interactions with, mainly because of the very clinical and provider focus of health plans. But we really have a fair amount of work, I think, to do at CDC anyways to improve cardiovascular health across the nation by engaging employers and helping our funded entities engage them as well. Because we do know this all really the change has to happen at the local level.
And that's where community health workers, too, can be so advantageous, really. The more we can put community health workers in many of our communities throughout the United States, they're doing a fabulous job with this whole social determinants, health equity at a much lower cost than some of the other strategies that we tend to use.
Yeah, I'm glad you brought that up because I think we've heard the concept team-based care several times today too, but I wanted to be really clear that the team needs to go beyond the clinic walls and include the community health workers and community pharmacists. There is good data, great data, good enough for John and others at the Community Guide to, endorse not just community health workers, but collaborative practice agreements, the role that pharmacists can play, for example, with increased medication adherence and related to hypertension. So that team-based care is critical.
And one of the reasons it's so critical, I'm going to go back to my database. I'm a data geek, if you didn't know. One of the issues we looked at when we saw patients coming in with hypertension is of the patients coming in with hypertension, only 9% was that their only problem. The other 90% had all the other chronic conditions. They all had heart failure or diabetes or behavioral health issues, 4, 5, 6 chronic conditions. That's why you need a team-based care, because you can't just address the hypertension. They've got a whole host of other issues that need to be addressed. Those are where the team-based, the pharmacist, the nurse practitioner, or advanced practice clinicians, the community workers, the whole team has to unite, because these patients often are overwhelmed, and hypertension is maybe lower down on their list to address, and they've got other things that take priority.
So we have a group sitting in front of us who are cross industry collaborators. What can our National Forum members do today to help do things differently when we think about risk factors? Do you want to go start first?
Well, I think, again, that common vision is so critical, and just taking the time to make a phone call, to reach out. So many times we have big dreams, but then we have fears that hold us back from taking risks. Sometimes we just have to do it, We have to pick up that phone, call somebody else and say, let's get together. I have this idea. Why don't we meet and flesh that out?
Again, it differs by who you are sitting out there in the audience, but I think one key factor, no matter what your role is making it a priority. And for me, and I think Jerry anyways, it's hypertension control. But if you make hypertension control a priority, we have seen that regardless of where you sit, you can have amazing impact if you just follow through on that. And you can get the rates up from a hypertension control rate of 48% to 60, 70, 80, even 90%, regardless of your setting, if you make it a priority. So for employers, it might be in health plans, there's some similarities for both employers and health plans in terms of what's under their control, even without large community collaboration. Covering self-monitored blood pressure, covering the devices so people can do that. Making performance for cholesterol and hypertension control part of your performance measures that you follow, and you base your insurance package on that. You do value-based insurance design, in other words. And, we can do that at the national level, but employers can do that for their own plan as well, as can health plans for that matter. I think Jerry's already mentioned the really true meaningful use of electronic health data can help if you're in a community collaborative setting or if you're an individual health plan or employer. So I think those are a few trying to give you some specific ideas about what you might be able to do that those aren't really that heavy a lift. The last one is a little harder for some folks, and that is the linkages. We keep talking about some clinical settings and community settings, and we have to link those two together. It's really critical if you're going to address social determinants of health. But it's important because people with hypertension or high cholesterol or heart disease spend so little of their time in the clinical setting. They're out there in the community. So we have to increase those linkages as well.
I think, too, we have to remember the power of story. I work every day trying to motivate our population how to make behavior change. And I will tell you, I can give them all the startling facts in the world, and their behaviors aren't going to change unless crisis happens or their emotions are raised with good, powerful stories. And sometimes we forget to combine evidence with story to help people make behavior change.
And that highlights to me, too, a couple of hallway conversations I had around evidence-based strategies, and how can we, when we are employing evidence-based strategies, really do a better job, I think, of studying, so implementation science, and promoting what we learn about what works on those evidence-based strategies, as well as what doesn't work when we apply those evidence-based strategies to another population or another setting. So I'd like to tag that also as well. Any last words that you want to add that national forums can do, members can do, before I turn it and open it up to our guests and members for questions?
I agree with Betsy and Bernadette. Excellent. Lots we can do. Boy, it just seems like we've been working on hypertension for years, decades. We have the medicines. We know the guidelines. Some of it is just do it and just get people, accountable, following the best practices, and their leadership involved and engaged. That's on the provider side. And these linkages, definitely, I agree. We've got to work cross silos, cross function if we're going to make a real dent in it together.
So we can open that up to questions.
Kim, I want to take the prerogative of holding the mic to ask the first question. I think Betsy and Jerry have pinpointed one opportunity, which is working through existing clinical systems to achieve better blood pressure control. That we know how to do it. Jerry's organization, AMGA, did it brilliantly, or led many of its members in doing it brilliantly with Measure Up, Pressure Down. Congratulations again. Huge contribution to Million Hearts. But Jerry mentioned the social determinants. And if you look at all the OECD countries, all but one invest $2 in social determinants for every dollar that they spend on health care. All but one. That one is us, the U.S., where we're upside down on that equation. We invest 55 cents in social determinants for every dollar that we spend on healthcare. Now, healthcare is what, 18.5% of GDP? So we're talking about this massive industrial complex with a lot of people who have strong interest in maintaining the status quo. So I'm going to put you, Jerry, since you raised social determinants, you on the spot, perhaps Connie Wong, Mike Kropp. How can we begin to change that equation? How can the U.S. begin to come into line in its investment in social determinants and the upstream prevention that we know needs to be paired with the clinical practices and programs to bring hypertension control to a higher level?
I'll talk at the local level. I think some of this is government policies that, on payment policies on what we pay for. But on the local level, my feeling is that as we move to accountable care, as we move to provider organizations being accountable for the cost and quality of a defined population, the social determinants just rise to the top very quickly. If you're going to manage the cost and prevent avoidable emergency room visits, if you're going to prevent avoidable high-cost illnesses, if you're going to prevent unnecessary admissions, readmissions, et cetera, where the costs are, you're going to have to address the social determinants. So I feel that it will happen as the payment reform system evolves, because if you're going to manage a population, you're going to have to manage, or you're going to have to at least address the social determinants. And that's on a local level. On a national level, I defer to my government people to tell us how we're going to do that.
Well, I think you just answered it, Jerry. I mean, right now, as things currently stand, it's through alternative payment models or through a model that's, through the Centers for Medicare and Medicaid, Center for Medicare and Medicaid Innovation that is successful at addressing the social determinants of health while maintaining or improving quality and not increasing cost. That could then be rolled up to scale. Short of that, it takes legislation. So if we can bear fruit and from the alternative payment models that are being piloted and underway, that'll get us, that'll get us at least part of the way. I don't have any great answers other than that.
Okay. Hi, can you hear me here? I wanted to back up into an area we've been talking a lot about, the Simple 7 and getting people on the right preventive path. And I don't think I heard much discussion, in this group, and maybe appropriately so, but going back into the schools and teaching children about this. And one example that was really interesting to me, I was working on a stroke prevention research program recently, and there was a program from a neurologist, Dr. Jide Williams from Columbia, called Hip Hop Stroke. And it was a really innovative program. We're showing, in this case, educating children about stroke and also about risk factors, in part through a series of very, very clever videos. And, they tested it out, and kids retained stuff, and they retained it for more than a year. These are 4th to 6th graders. And the idea was that, and I don't know if they've tested this out very well, that this is an age group where the kids talk to their parents and they would transmit this to their parents. But the general idea is, what can we do when kids are really young, when they really need to get started, because all of these things are really lifelong disorders.
I think you raise an outstanding point. I always say childhood is the foundation for the rest of life. And if we don't instill these good, healthy lifestyle behaviors plus positive mental health in our kids, this is what we're going to see years down the road. We teach math, social studies, writing. Those are all very important, but not more important than giving our kids the life skills that they're going to need to lead very productive adult lives. And kids can act as great agents of change for their families. Our studies have shown that. So teaching kids the skills and asking them to put them into practice by going home and teaching their families is a great way to get to a lot of families.
Dr. Labarth?
Thank you, Donald Labarth, Northwestern University Preventive Medicine and National Forum. Carrying further the point that Steve has made and some of Bern's comments, one of the goals of cardiovascular health, I would say, is cardiovascular health. We know that at about age 10, the prevalence of ideal cardiovascular health as defined by AHA is about 50%. We know that at age 50, the prevalence of ideal cardiovascular health as defined by American Heart Association is about 10%. And if you can visualize that picture, 50% at 10, 10% at 50, you have to ask, what's wrong with this picture? Our commitment is to improve the cardiovascular health of all Americans by 20% by 2020 in terms of the current strategic impact goal of American Heart Association. while we should be improving the cardiovascular health of all Americans, we are watching it decline. What's wrong with this picture? What can we do about that? We don't know the prevalence of ideal cardiovascular health at birth. We're working on how to measure that and how to monitor it and how to modify it when necessary. But what we do know is that ideal cardiovascular health is declining. We see the downward slope. It's low at the beginning, only about 50% at age 10, and we can't tell yet what it was at birth. And we know it declines to about 10% by age 50. If you had ideal cardiovascular health at age 50, substantial data have shown you may have a 40-year life expectancy free of cardiovascular disease events, better quality of life, lower medical care expenses. So it seems two things we need to be thinking about, and much of what we've discussed could be considered as applied to that part of the picture. And it is to say, number one, stop the loss. Sustain the cardiovascular health that we have at age 10 and however much earlier. Second is to increase the prevalence of ideal cardiovascular health at birth to as near 100% as we can get it, free of disparities. David Goff, my colleague, is fond of saying about getting research funding from the National Heart, Lung, and Blood Institute. It's simple. Write a good application, and you'll be funded. Well, this is simple. Stop the loss and increase the prevalence at birth and sustain it through adulthood, through the life course. Two simple steps. Not easy, perhaps, but simple. And I think in a future discussion, we might well turn to a fuller examination of how the many important points made here about remedying the problem can be applied to promoting cardiovascular health in the first place. But thanks very much for this session. It's been excellent. Vern, thank you.
Just talk.
Thank you. I'm Margot Warren. I'm from the National Institute of Neurological Disorders and Stroke at NIH. And I was just at a meeting of the American Academy of Pediatrics, and it struck me that that's a wonderful organization, right, the audience we're talking about today, and I wondered if anyone has attempted to partner with them.
I'm a member of NAPNAP, which is appropriately the National Association of Pediatric Nurse Practitioners. And we have a solid relationship with the American Academy of Pediatrics. Really two great organizations to promote the health and well-being of children.
Just highlight with the American Heart Association. Actually, we just highlighted a report that was released, I believe, last week. I'm having a little trouble on which week it is, but around what are appropriate beverages for children and the recommendations around those. And we also partner with the AAP when it comes to broader nutrition guidelines, and as well as, I think, as Dr. Labarth was indicating, the challenges that we have with data collection in under the age of 10. So those are just some areas where we have collaborated. But I think you're right in that, and elevating AAP, as they aren't always around the table when we talk about across the life course. And I think highlighting across the life course as we began this conversation is a big piece that we hadn't raised yet.
Well, I find that interesting too. I had mentioned to John Clymer during the break that if I hadn't quite understood what the earlier session on force readiness was really going to play out as, but the focus on prevention and pediatric issues in children are the way CDC is set up. Many of you know this, but our division really does focus more on the hypertension, hypercholesterolemia, and the burden of stroke and disease. That we do fund prevention, absolutely primary prevention, or what some of you call primordial prevention, but a lot of that work is carried out in our division of nutrition, physical activity, and obesity, who and they and other parts of CDC work very closely with AAP on some initiatives. Our division, not so much, but certainly an important partner.
It'll come.
Hi, I'm Kelly Myrick of the National Center of Health Statistics. I just want to thank you for this wonderful panel. It was very insightful and very helpful. So one thing that I think should also be included is thinking about sleep. MMWR report came out from one of my colleagues just this week that said approximately 21% of women between the ages of 18 to 64 had never had a restful day, a night of sleep in the past week. That is very troubling, especially since we know the impact of sleep on cardiovascular disease, and we also know that there's a huge connection between sleep apnea and other sleep disorders and hypertension. So I was just wondering whether that's something that you discuss or cover in any of your programs. Thank you.
I'd say just with AHA, we have increasingly been talking about how do stress and sleep sit within the Life Simple 7 as we talk about it, and are they within because they're on the front of it, or are they a part of those 7? And those behaviors are so important, and you're so right. We are increasingly seeing the impact and the effects and how that impacts mental health as well, ultimately, and then how does mental health address drug disorders and alcohol abuse and other things that are contributing to, particularly in women, middle-aged women, the declines in life expectancy that we are seeing in certain populations. So that is a great point, and thank you so much for bringing that up. I don't know if anyone else wants to comment as well.
I'll just give it some context. These things, sleep, stress, gosh, they're all important. Now, you got a 15-minute visit with your physician, okay? 7 of those, that physician's typing into the computer. So now you're down to about 7 minutes. And of course, they have to renew your medications, et cetera. So it is team-based care. We need an extended team to help address some of the other issues that you just can't address in 7-minute office visit.
We also need full reimbursement to focus on some of these issues, because so many providers will say, unless I'm reimbursed to do X, Y, and Z, I just can't do it.
I just want to thank my panelists and for the audience for an engaging conversation, and we will set up for the next panel, I believe, next. Thank you, everyone.